And we're back.
Okay, good. This is Senate Health and Welfare. We're back on live, and we're looking at S36. And Eric, just at the highest level, we have a new draft on our webpage. If you could just share with us what has been changed there, just really briefly.
Yeah, sure. Thank you, Eric Fitzpatrick with the Office of Legislative Counsel, here to talk to the committee about a proposed new strike-all amendment to S36, which is the activating and arrest without a warrant for assaults and threats against healthcare workers in healthcare facilities. And as the chair mentioned, there's a couple of new additions to this version of the bill. And you should be able to see that highlighted in yellow if you look at the actual language. But in the big picture description of what are these new pieces and what are they doing, the first one, which if you happen to be looking at the text, is a new section 3 of the bill, which would be pages 2 through 4. And what this does is it adds, remember the committee had been discussing the idea of the existing offense of criminal threatening. And that during the course, I think you may remember with the joint hearing with Senate Judiciary, the topic came up and there was interest expressed at that time because there are some existing pieces of the criminal threatening statute that apply some enhanced penalties to persons depending on the role or their status as a particular employee, that kind of thing. You know, there's some, for example, for DCF workers, there's some enhanced penalties for poll workers, other government employees, that kind of thing. And so I think the interest had been as well, and it didn't have anything about an enhanced penalty for healthcare workers under the current law. Doesn't, I should say, not didn't. And the committee wanted to look at language in which that was added. So in other words, it sort of parallel the existing enhanced penalties for other types of employees or persons in different roles to add some enhanced penalties for a healthcare worker. Particularly in a situation, I'll just speak, it is very brief, so it might be worth thinking about the language. Again, this is first draft at the language, obviously may get at what you were kind of thinking of, or may need some tweaking. But it's on page 3, subsection G is the new language. So a person who violates subsection A, that means you violated the criminal threat statute. So if you engage in a criminal threat with the intent to terrify or intimidate, and that language is tracked from the previous subsection, they use that language. So that just isn't pulled out of nowhere, I guess is just what I'm saying. So it uses those same terms. With the intent to terrify or intimidate a healthcare worker because of the worker's previous action or inaction taken in the provision of healthcare services. So in other words, they're attempting to terrify the healthcare worker because of something they've done previously with respect to providing healthcare services, their action or inaction. Shall be, so that one gets the enhanced penalty to 2-year misdemeanor, proposed anyway. So that's the idea, to, I don't know if it addresses exactly what the committee was seeking to address, but at least it gets the topic out there to think about whether it does what accomplishes what you're seeking to accomplish. So that's one. 2 is a report on de-escalation. So that has also been added, and that's in the very last, second to last, I should say, section 5, page 5, section 4, page 5. And this requires several entities, Association of Hospitals and Healthcare Systems, Vermont Program for Quality Healthcare, and Vermont Medical Society to jointly report to this committee and House Committee on Health and Human Services regarding de-escalation of potentially violent situations in healthcare facilities. Report would include best practices for de-escalation, types of de-escalation practices currently in use, barriers to training, and resources needed for new or continued training. So I think the committee is also looking for some feedback on the de-escalation topic as well. And so again, just the first draft of what the report might look like, but
Good. I
So
think
that's
this is good, and this will be helpful to folks who are testifying. What I'm going to do is suggest that we not ask questions and engage at this point, but that we hear from our witnesses. But I want to make sure that we witnesses knew we had this discussion draft. So
yeah, sure.
that's it. Thank you.
Yes,
Great.
glad to help. And
Very good.
happy to hear from the witnesses or have other questions or want to
I'm
make
sure we
changes or
will.
whatever, just let me know.
All right.
All right,
All right, good.
thank you.
Thank you. And
Yeah.
Heather, you're here.
I'm just listening.
You're just
You kick
listening.
me out if I'm over capacity.
Mary, please come up and state your name for the record, and we're welcome. We're glad you're here. I'm going to go around and introduce Senator Gulick, Senator Weeks from Rutland, Senator Gulick is from Chittenden North, no, Central, gosh, I'm not getting my card. Senator Williams is from Rutland, and Senator Harley, Senator Lyons.
Good morning. Good morning. My name is Mary Moulton for the record, and I'm the Executive Director at Washington County Mental Health Services. Thank you very much for letting me testify here on S36, and I'm also testifying on behalf of Vermont Care Partners, which represents the designated agencies and specialized service agencies in Vermont. So this is certainly an important bill, and one that I know you've heard some compelling testimony on, and I'm here as a person who has worked in the field for a long time to express my appreciation for those that came forward. That is difficult to come forward and tell your stories. At the same time, I'm also here to advocate for those who have mental illness, substance use, and intellectual and developmental disabilities, as well as autism, to make sure that there are enough guardrails or that the language is right within the bill so that we do not have unintended consequences. So I want to share a little bit because I've been around a long time. I'm old, I always tell everybody, so I've got a little history here. And so as a person too who can appreciate the experiences out in the field, I worked as a mobile mental health crisis worker at Washington County Mental Health for 15 years. And as such, I worked both in the community and I worked in the emergency room. In the emergency room, I've had the experience of being thrown against a wall, of being choked, and of being threatened with murder. In the community, I have been held at gunpoint and I have been sexually assaulted. So this is something I can tell you I have never shared publicly. So I am sharing that with you in the context of also knowing that 75% of the people who were involved in those acts went to the hospital. And that is where they should have gone, including the sexual assault. So as we look and we talk about this bill, I want to highlight a couple areas of concern, and perhaps they are covered and they are implicit in other law. Medical clearance, I know you've talked a lot about. So medical clearance and what it means to be disorderly, okay? And I'm going to give you a couple of examples. So you may find it interesting to know that when I began my career 30 years ago, medical clearance actually did not exist. For those, my glasses are fogging as I talk. But it didn't exist for those who were going into the hospital for psychiatric inpatient services because, amazingly, there were no waits in emergency rooms and people were direct admitted. So we would do an evaluation in the field. Sometimes a doctor would come out with us and people would get admitted onto the unit. There were a couple of bad incidents which actually propelled psychiatrists to come forward across the state and develop a protocol for medical clearance through the emergency room. So when I say bad incidents, I mean someone was up, for example, on a unit and they had been admitted and they had had a sudden mental status change and come to find out they had a brain bleed. And so that had not been looked at. So obviously we needed to be looking at people medically. That's what began to happen, and Dr. Bill McMains of the Department of Mental Health developed a definition for medical clearance. And I know you were seeking one, whether it's in statute, and perhaps Devin has found that out or not, but it is a clinical piece that doctors do. And what this did was compel all admissions or potential admissions for a mental illness to go through the emergency department for a medical check. So that was a change for emergency rooms, an influx there. And then we had Tropical Storm Irene and a tremendous influx of people who were coming into the emergency rooms, and law enforcement was more involved at that point in time. And in some hospitals would be bringing people in, staying longer, being present. Some hospitals got security and hired security during that time, as they're just very tight spaces. Emergency rooms have, as you all know, I'm sure you've been there, have very tight spaces. And there's more opportunity, even if someone doesn't intend to harm, that if they are using their body or they're flailing or whatever they may be doing because of their symptoms, they could hurt someone. So we flash forward to today. We flash forward to a time where there isn't as much law enforcement. We don't have sheriffs waiting with people. We don't have that kind of support as much anymore in emergency rooms, if at all. And the first part of the bill we certainly want to support is that of training on de-escalation techniques. So certainly we're in favor of that. And I did want to mention that the Department of Mental Health did a good job years ago after the Vermont State Hospital washed away of bringing in training and actually being able to tease out what a law enforcement officer could do, what a nurse and a hospital team could do based on CMS regulations. They may be able to assist, and I heard the list that was mentioned by Eric, so perhaps they could draw from some of their training materials because I don't believe they do that anymore. So very much in favor of training. I'll flash now, go forward a bit to what does medical clearance mean? And here's my concern based on experiences in the emergency room now. So the bill has some language that speaks to if a person is medically cleared, what information could be given to a law enforcement officer that's sufficient to confirm whether the patient is medically cleared, and that they could then be removed and charged essentially. And of course, we know that that charge will not mean lodging. So this person, if they are charged for disorderly conduct, are likely not going to be lodged anywhere. They're going out into the community. So that is a concern. And also enhancing concerns about behavior that might be considered extremely disruptive. There's language in the bill that says the person has committed a violation of disorderly conduct that interfered with the provision of medically necessary health services in a healthcare facility that can also render a charge. So a couple of examples when I visited the ER one day to bring in a state official. This was just this year, and I think it's a good example of why I'm concerned about individuals and unintended consequences. We had a young adult with autism who was in the back of the ER in the area that's assigned for people with psychiatric crises. And the shared living provider or caregiver had decided they could no longer take care of the person due to aggressions that had been happening and assaults in the home, and they brought them to the ER. And of course, then the question was, Washington County, how quickly can you build a program 24/7 for this person? So that's going to take time. And that meant that our hospital was on the phone with us every morning, talking with us in concert, very collaborative around what the next steps would be. And the words were, she's medically cleared. So when will the program be ready? So technically, this person was cleared to go. We did not have the program. So in this case, the person stayed, but there were definitely escalations. At the same time, because that milieu was full, a person who was on an EE and mental health crisis was up in the general milieu. And the conversation was, this person is disruptive, they are hollering, they are threatening, and they are on an emergency exam right now. But this is extremely difficult for our other patients. And absolutely, there are children who could be running by. This is not a good situation. We all agree with that. But being concerned about whether a person with a developmental disability could, in this instance, say, have an escalation and there isn't a collaborative team, could that person then be released and charged? I am concerned about that, and I believe there should be some guardrails or language in the bill. Perhaps it's in the definition of medical clearance. Perhaps it's simply written differently, and I've got a suggestion or two that I'll give you right now as I conclude. The other is if a person is on an emergency exam hold status found for involuntary hospitalization or voluntary hospitalization, that they certainly not be discharged. And I can tell you there have been instances where people are held in police stations while they're waiting. And that
would seem to me that could be a reference to a specific statute.
Yes, it might well be. And so I'm just, as you explore this, more questions that I have, but I wrote, for example, any person who has been determined to need voluntary or involuntary hospitalization due to a mental health crisis shall not be subject to the provisions in this bill that would criminalize any resultant behavior. It's the spirit of it. In addition, any person with an intellectual or developmental disability or autism will not be subject to having their behavior identified as criminalized should that behavior be a result of a mental health crisis or manifestation of unmanageable stress directly related to that disability. Again, the spirit of it, how do we get to that? And then the same with someone with dementia, etc. So with this, coming from that spirit, however we could formulate that protection within this bill would be very important. Lastly, I would recommend some level of tracking take place regarding the implementation of this law to make sure we're not having these unintended consequences. And how many times, maybe how many times did law enforcement respond to issue citation of warrantless arrest? Given the use of force law, I'm not sure that's going to be that often, frankly.
Yeah.
We're experiencing this in the field, it's difficult. And also noting within that tracking, how many people are also involved from our BIPOC or LGBTQ plus communities, where we know that there are vulnerabilities and health disparities. So
we have this, we have your
you have my
recommendation.
written
This,
testimony.
yeah,
Yes.
this is gonna be, it might be a joint effort by two different village councils at that point, so we'll have to evaluate that.
I appreciate the consideration.
And Jay is here, and if the committee doesn't mind just taking a step over our time so that he could testify, that would be helpful.
Absolutely. Any further
And then
questions?
we will have time for a conversation.
Okay, and of course, I conclude with saying that the root of all of this is a lack of upstream services for individuals. So we're actually working to protect when we should really be working to prevent. And I just need to conclude with that. I thank you very much.
Thank you.
For the
Our-
opportunity.
With apologies for the limitations on our time.
Absolutely. You have my written testimony. Thank you, senators.
Jay, welcome.
Good morning, senators. Thank you very much for having me. Chair Lyons, thank you very much. Jay Green, I'm the policy research analyst for the Office of Racial Equity. I use they, them pronouns. And I'm here to briefly testify on S36. And I just wanted to note for the record that my testimony is based on the previous draft of this bill that did not include the elements that Councilor Fitzpatrick shared this morning.
And we have your written testimony.
Yes, I sent that to.
I can't access it on my iPad for some reason. That's why I keep asking.
No problem. Okay. Okay, thank you very much. So, so first I wanted to begin by saying that the Office of Racial Equity supports the affected healthcare workers who have testified to their experiences in Vermont's emergency departments, and their testimony really makes it clear that there is a safety crisis happening in our hospital systems. And although our testimony today is related to the impacts of law enforcement interaction on people with mental illness, this should not be construed to mean that all people interacting with healthcare workers in a disrespectful or violent way are experiencing mental illness. People with serious mental illness are actually less likely to commit violent acts than people without serious mental illness when statistical analysis takes into account the common factors associated with violent crimes, such as the presence of intoxication or environmental factors. So people not experiencing mental illness who are expressing their anger or frustration in inappropriate ways should be held accountable for their actions. The testimony from affected healthcare workers clearly shows the pattern of people not being held accountable when they are acting in ways that are severely disruptive and disrespectful to healthcare workers. But we are highly concerned that the passage of S36 will dissuade hospital systems from addressing their own internal practices related to employee safety by creating the appearance of change without an impact of an actual change. We believe S36 is unlikely to have the proposed effects of reducing healthcare workers' safety concerns. Simply addressing the issue through increasing the statutory powers of law enforcement is unlikely to change the outcomes that have been shared with us by so many healthcare workers in the past few weeks of testimony. In fact, we're very concerned that it's likely to increase the disproportionate and racially inequitable outcomes that are associated with increased law enforcement presence. So the following are two statistics to consider with regards to the danger of law enforcement encounters. Black Americans are fatally shot by law enforcement officers at a rate that is almost 3 times higher than the rate of fatal law enforcement encounters for white Americans. And that is from the Washington Post Police Fatalities Database. This figure is likely to be an undercounting of the true rates of violence that are experienced by Black people in America at the hands of law enforcement, because the US government does not adequately track instances of non-fatal shootings or cases that are not prosecuted where law enforcement uses force against a person of color. The second statistic to consider is that people with untreated mental illness are 16 times more likely to be killed during police confrontations than people without mental illness. So we are concerned that S36 is likely to increase the negative consequences of law enforcement activities that disproportionately impact people of color without addressing the root causes of violence towards healthcare workers. We are also very concerned whether the proposed statutory changes and under S36 will actually hold people accountable for their actions. And I'm going to, just because of the limited time here, I'm going to skip the part of this letter of testimony where I describe the existing protections on from healthcare workers, 13 VSA 1702 and 13 VSA section 1028, which specifically defines protected professionals as the employee of a healthcare facility or licensed physician who is on the medical staff of the healthcare facility, who provides direct care to patients, or who is part of the team response to the patient or visitor incident involving real or potential violence. So there are existing protections for healthcare workers in the Vermont state statutes already, which is something that Vermont Defender General Matthew Valerio testified to on February 2nd before the Senate Judiciary Committee. We also consulted with our equity liaison in the Vermont State Police, and we heard concerns from them that F36 will not have the intended effects because it is duplicative of the existing rules of criminal procedure. This was also raised by Defender General Matthew Valerio in his February 2nd testimony before the Senate Judiciary Committee. We also heard strong concerns that were echoed by Mary Moulton today that the passage of S36 would lead to unnecessary or disproportionate law enforcement intervention in cases of people with mental health concerns undergoing a crisis situation. And we note that law enforcement should not be charged with removing people experiencing mental health crises from facilities where they need treatment. This raises the possibility that the passage of S36 would lead to unnecessary law enforcement intervention towards people with severe mental illness. And these reflections from the state police echo those shared by Director of Mental Health Law Project at Vermont Legal Aid, Jack McCullough, in his testimony on S36, also on February 2nd before the Senate Judiciary Committee. We also learned through our conducts with the Vermont State Police that law enforcement officers are sometimes turned away from hospital emergency departments by administrators who state that they wish to handle their disturbances internally, not making a blanket statement about all hospital administrators or how all hospital emergency departments in the state, just that this was the testimony that the state police wished to share with us. The state police experience raises the question of how S36 would have the intended effect of making healthcare workers safer when hospital administrators do not wish for law enforcement to intervene on their premises. I'm not sure how it's helpful for law enforcement to have the additional powers to arrest someone after the fact when it seems like the intervention is needed in the moment at the time that the incident is happening. So we understand that the bill before the committee today was developed in response to requests from affected healthcare workers to do something to prevent the violence that they are currently experiencing. However, this bill is unlikely to change the outcomes at healthcare facilities and is likely to increase the potential for law enforcement violence against people of color in the state. Therefore, the Office of Racial Equity opposes the passage of S36. And for a path to specifically address the concerns of people experiencing mental health crises, we recommend looking into the Justice and Mental Health Collaboration Program from the Center for State Governments. They recently released a toolkit for creating mental health crisis response teams that work in tandem with law enforcement while not additionally criminalizing people with mental illness. And the letter of testimony that I submitted has a link to the Center for State Government's website where you can find more information about that toolkit, which I think has some really promising solutions for addressing people who are having mental health crises while not additionally involving unnecessary law enforcement response. So that was my testimony for today, and thank you very much for the opportunity. I'm happy to take questions, although I note that we're over time, so you can also email me.
Thank you, and thank you for submitting it so that we do have it and we can review. Specific suggestions that you might have for approving the bill would be helpful. I know that Mary Moulton did make one in her testimony about tracking what happens should the bill be passed, what happens with patients who are BIPOC or LGBTQ, and how to ensure that there's equitable treatment across the board. We also understand the need for comprehensive improvement to our mental health system. But this isn't about people. This is not really about people with mental health issues or substance use disorders. So if we can disabuse folks legislatively about that, that might help us move forward. It's not about, it is about protecting nurses and others who are working in healthcare facilities. We heard dramatic testimony around that.
Yeah, and
So this is important to have a dialogue as we go forward, and I hope that you'll stay connected with what we do.
absolutely, yes. And I just wanted to note that there are disparities in access to healthcare and access to a mental health diagnosis that exist for people of color and for members of the LGBTQ+ community. So if the legislature takes the route of specifically creating exemptions for people with a diagnosed mental health condition, we're still going to be excluding people who do not have access to mental health care. Perhaps this is the first time that they're presenting to the emergency department for a mental health concern, and that's just not known yet. So we're essentially saying that we would really like the legislature to consider that we already have solid information that suggests that taking a law enforcement approach to behavioral incidents is not going to be helpful and is going to disproportionately impact already marginalized groups. So we would really strongly encourage you to consider whether this legislation really addresses the root causes of violence in our healthcare system, or whether it's, yeah, I mean, I appreciate the addition of the reporting language, but I think there's already sufficient data to understand that there is a very big concern for disproportionate outcomes without, just from the beginning, like we know already about the potential for disproportionate outcomes.
Thank you.
Thank you.
Thank you very much. Okay. And we'll circle back to this bill as we go forward. We have some suggestions that have been made.